Okay, so Assalamu alaikum and good morning, everyone. Welcome to the third episode of Medet CR. I'd like to welcome our brilliant speakers and attendees, and maybe now they can start introducing themselves to our audience. And then Dr. Abdullah later on can take it from there and start the case.
Assalamu alaikum. My name is Ali Al Shidi. I'm a consultant internal medicine at Tuam Hospital. I'm happy to be with you here today, and I hope I can benefit myself and you with some of our experience in treating patients with dyspnea. Thank you.
Our discussants, maybe you can start introducing yourselves.
Good afternoon. My name is Aisha. I'm a fifth year medical student, currently studying at CMHS. I'm interested in cardiology.
Hi, good morning. My name is Maitha. I'm also a fifth year medical student in CMHS as well. I have a lot of interests from medicine to pediatrics to OB/GYN. All of it's interesting. So yes, I'm happy to be here today.
Okay, hello everybody. This is good afternoon. My name is Abdullah. I'll be the one presenting the case. I am currently an R2 internal medicine resident at SKMC. So can we start?
Yes, definitely, Dr. Abdullah, you can start.
Okay. So I'd like this session to be interactive. So I'll ask question as I go along the way, and then later we can hear or we can read questions from and comments from the audience. So let's start. We have a 50 years old male patient. He's known to have diabetes, dyslipidemia, presented to the ED with 1 week history of cough and shortness of breath. The cough is productive with yellowish sputum, and it's not associated with any timing or any pattern throughout the day. There is fever with cough, which is subjective, and shortness of breath and chest pain. The patient gets short of breath throughout the day, which mostly during exertion, sometimes at rest. The shortness of breath is not increased at night, and the chest pain is mostly pleuritic, which means that chest pain is increasing with the respiration, with inspiration or expiration. There is no trauma to the chest. This is the first time that this patient is having that kind of symptoms. There is no weight loss and there is no hemoptysis. So Asha, so let's start with the history. So what things you would like to add on to the history? What further things you would like to ask this patient?
If there is any recent travel history.
Why is that important?
لأنه he have a cough, which is productive cough. It could be TB. We need to rule out TB بعد.
Yeah. So, okay. Asha, you mentioned, okay, let's go to Maitha. Maitha, Asha mentioned TB. So what further things that would point towards TB? What things that you would ask this patient to rule in or to have a higher suspicion or low suspicion for TB? So what things you need to know in regards to TB for this patient?
Okay, so for TB, first there's epidemiological factors. So where is this patient from? What country? Has he traveled recently? Has he been vaccinated? Has he been in contact with anyone who's recently been sick? And then there's symptoms wise, night sweats, weight loss, any hemoptysis, but he said no weight loss, no hemoptysis.
Yeah, so he doesn't have any night sweats, and he's from Pakistan. He's been here in UAE for 4 years now. He hasn't been treated for TB. He hasn't been in contact with any patients with TB. Please be in mind that patients mostly TB is a very common condition, and many patients, they would know TB. So please ask them in the history, have you ever had any TB, or have you ever had contact with any patient with TB? So they know what TB is, okay? So you have to ask them that. Okay, so he has no contact with patients with TB. Okay, what other things you would ask? Like in regards to dyspnea, not TB. Things that would help you know the cause of dyspnea in this patient.
Okay,
Mesa,
so
Asha?
is it worse when you lay down? Do you notice that it changes if you're laying down or sitting up, which could point us towards dyspnea due to pleural effusion or some sort of other cause like that, something to do with water accumulating in the lungs? What other things? Is it by, we mentioned already that it's during exertion versus at rest.
Yeah, but he has it at rest as well. But let me elaborate more. Sorry, Mesa. Sorry. Let me elaborate more of the positional dyspnea. You said water accumulation. So what other things that would really present or with a patient with water accumulating in their lungs or pulmonary edema have? Which symptoms, which signs, which symptoms, I mean, would they typically describe?
Shortness of breath. They could feel a peripheral edema if it's from congestive heart failure or something.
Yeah, so
on multiple pillows, more than 3. Or
yeah,
3.
what do you call that? What do you call that?
You mean the paroxysmal?
No, that's not paroxysmal nocturnal dyspnea. Okay,
is it,
so
orthopnea?
Yeah, right. Orthopnea. So orthopnea means that the patient he has difficulty lying flat, so he needs more pillows to help him sleep at night. So you ask about the patient, did you have any have you had any need to increase your number of pillows to have comfort while you're sleeping? So that's the question you would ask for patients with orthopnea. The other question, what does paroxysmal nocturnal dyspnea means?
Is it when you sleep, you're woken up from your sleep because you're short of breath?
Yes, that's right. So you have to ask about that. And that's a little advanced, but I'll tell you. There is another thing which is called pendopnea, which is usually in patients with hepatopulmonary syndrome. So those patients, usually they get short of breath. It's the opposite for orthopnea. So orthopnea, they get short of breath when they lay flat. So pendopnea, they usually relieved when they lay flat, and they get short of breath when they bend.
Abdullah,
yes.
Can you give the spelling for the scribe to write pendopnea?
So it's a
you are giving hard time for the scribe. Okay.
Okay, it begins with B from banana.
Okay.
Yeah, so that's usually for hepatopulmonary syndrome. That's really advanced. You don't have to do it. You don't have to know it. But okay, that's something for you. Okay, so other things you would ask. So we pretty much we covered everything about past medical history. Other things you might ask is anxiety at home, but that really comes late in the differentials. But you need to ask about psychiatric history. I saw a lot of patients who came with dyspnea, and they usually panic attacks. Okay, so please ask about anxiety. Usually, if you think they're young, they have some, for example, a patient who was in a school and he came at the day of the exam having really dyspneic with chest pain. You think of panic attacks, but that usually comes late at the differential. So you need to rule out other causes.
Okay, Abdullah, can we pause for a second just to recap?
Yes.
So thank you very much. It sounds a good case that you choose. So a few things. I just want to make sure we benefit from them. The first thing, when you start presenting the case, they should be the presenting complaint front on your presentation. So it's good to mention the past medical history or any other issues in the past, but please start with the presenting complaint. Now your presenting complaint is there, which are more than one. So this patient has fever, shortness of breath, cough, and chest pain, okay? So before you go for the negative, like history, I would suggest that you elaborate on these presenting complaint separately, okay? So for example, what is shortness of breath? What is cough? What is chest pain? Each of them, you elaborate on them separately. Later, you can combine this elaboration to come to one list of differential diagnosis. After that, you can go and start to ask the negative history or system review. So what your colleagues did, which is good, for example, they ask about what type of shortness of breath. Is it orthopnea? Is it paroxysmal nocturnal dyspnea? Is it related to a disease which can cause also hemoptysis? Is it travel related? So how about going back and starting to elaborate on dyspnea itself? So apart from orthopnea, paroxysmal nocturnal dyspnea, I would ask you what terms you would use to ask the patient, what does they mean by shortness of breath? So can you give me some terminologies, like 3-4 terminology? When you talk to your patient, you ask them, what do you mean by shortness of breath or dyspnea? What do you think they will say? This question for everybody.
I can't breathe. I can't take a deep breath.
Excellent. So I can't breathe. Doctor, I can't breathe. What else they can say?
It hurts when I breathe. They could say, I can't take a deep breath.
Okay.
I can't get the air in or I can't get the air out.
So you see, there are lots of terminology. So for shortness of breath or dyspnea, probably differ from one person to another how they describe it. Probably the mild format, they feel some uncomfortable feeling, okay, while they are breathing. But the extreme, they may tell you, I'm suffocating, isn't it?
Yes.
Yeah. So there is spectrum of like way how the patient can describe it, but finally it is what? A shortness of breath. And unfortunately, that we cannot control. So that's related to each process and each disease. So for example, when you get somebody with shortness of breath because of heart failure, it's different from somebody coming with shortness of breath with bad asthma attack, or somebody who's coming with panic attack or anxiety. So it's important to take the exact feeling for the patient. Why? Because dyspnea or shortness of breath at the end of the road, is it what? It's sensation, isn't it? It's one of the sensation, isn't it? Do you agree with that? Yeah.
Yes.
So it's sensation. So remember, shortness of breath is a sensation that I sense something wrong, which is probably I can describe it as I'm air hunger, or I can't breathe, or I'm suffocating. So that's a feeling. So the patient describing their feeling of dyspnea. Okay. So very important to elaborate on these presenting complaint before you go further to others. So again, do you want to elaborate on fever? Do you want to elaborate on the chest pain? Do you think it will make difference when you come to diagnosis or to differential diagnosis? Or you are happy you wanted to go and proceed with the examination, or whatever Abdullah is preparing?
No, we need to ask more about the chest pain. For example, if it started sudden or it was progressive, does it radiate?
True. So sudden pain, is different from something which been there for days and days, okay? So sudden means something different from something coming slowly and then increasing in severity. Excellent.
What else you would ask about pain? You said radiation.
So the nature of the pain, what is
Yeah.
the character of the pain? For example, what could the patient say when they describe their chest pain?
Could be stabbing, could be pressuring.
Yeah, okay.
So this patient usually the pain started 1 week ago with the shortness of breath. It's usually when the patient takes a deep breath because he's tired, he cannot take. He feels like he's short of breath. Basically, it's difficult for them to breathe. They feel chest pain along with that. Okay, so this is what this patient described the pain as. The pain usually didn't radiate. Usually in the chest wall, the pain is not sudden. It's not sharp. It's so you get what I'm feeling, what I'm pointing at. It's just a pain which is associated, which is because of difficulty in breathing. That's it. So this is what patient describes. Dr. Ali mentioned something which comes a lot in exams and usually in real life. And patients, when they describe the way they're feeling, usually when they say, I felt like I want to die, this feeling is usually panic attack. So please learn this word. Ask them specifically, did you feel during this attack that you wanted to die? If he said yes, then that's most probably panic attack. But again, you need to rule out other things. So let's move on the case. So past medical history, he's diabetic and dyslipidemic. He's on just give me a second. Yeah, he's on glimepiride for diabetes. Dyslipidemia, he's on atorvastatin. He doesn't have any history of recurrent admissions or previous admissions. Past surgical history, he didn't have any surgeries. He doesn't have any allergies. Family history, his family are well in Pakistan. He doesn't have, they don't have any chronic issue except his father. He has some heart disease, but he's old. His father is 65 years old. Personal history, the patient smokes 1 pack of cigarettes for 2 years. So this translates to how many pack years history? Metha or Asha, any one of you? How do we calculate the pack year history?
I always get confused by it, but do we just say 1 pack year for 2 years or 2 pack years?
No, you multiply 1 by 2. So 1 times 2, it's 2. So 2 pack year history. This is how you say it.
2 pack.
Okay. So if a patient smokes 2 packs for 30 years, that would translate to 60 pack year history. Okay, so you multiply the 2 numbers together. Oh. Do you get it?
Yes, okay.
Okay. So where were we? Okay, so we said he smokes 1 pack for 2 years. He drinks alcohol rarely, like only 1 to 2 times per year during occasions. But he's not been admitted to with alcohol withdrawal or intoxication before. So you start now with physical examination.
Dr. Abdullah, before we leave the history taking, which is, as you know, it's very important. When you started the presentation, your colleagues started to elaborate on the presenting complaint. I got the feeling they started to categorize their history taking, which is good. So somebody asked about infectious process like TB. Somebody else asked about probably cardiac component like orthopnea, paroxysmal nocturnal and dyspnea. and somebody else start to talk about hemoptysis, would may reflect again either infectious or old chronic disease that can cause hemoptysis or even acute process. So that's a good way. So when you go to take history from the patient, probably the presenting complaint is the same always, like shortness of breath, cough, fever, okay? But ultimately, the cause is different. So to make life easy for a medical student to gather information as much as they can from the first instance, what medical students usually do, and it's good, they put a category for each symptom. So for example, if this patient has shortness of breath, I would look for the etiology as pulmonary or pulmonary etiology that's coming from the lung. So it comes from the airways, it comes from the vessels in the lung, it comes from the parenchyma of the lung. Or I will ask history related to the cardiac component or cardiovascular.
Doctor,
Again,
I'll cover this after we finish the case.
okay.
I'll just give some quick tips on how to approach dyspnea and what things to look for. But
Oh.
I'm trying to finish the case first, so then we can go into dyspnea in details, okay? And you can add on that.
Sounds good. No worries.
Okay. So we start with examination. So what things you would do in examination? The first thing you need to do is what?
Check the vitals.
Vitals, okay. So the vitals of this patient, heart rate is 110. Respiratory rate is 32. Blood pressure is 146/92. Oxygen saturation is 88 on room air. Temperature is 37.8. So what things did I miss in the vitals? I'll tell you, blood pressure, both arms, okay? Always do blood pressure in both arms, okay? You don't want to miss an aortic dissection. Always do that in both arms, especially in sick patients, tachypneic patients, patients who you think that they're critical, okay? So this is the first thing you do. Those are the vitals. So when you see this patient, now before you proceed to the examination, you see this patient he's having low oxygen saturation and pulse oximetry.
Dr. Abdullah, can we pause? So every time you give us a set of information, try to pause and probably a small question for the student. So for example, now you gave these vitals, okay? I think the next question you should do is, do you think this patient is sick? If he is sick, mild sickness, moderate or severe from the vitals. So what do you think? Ask your colleagues what they think about it.
What do you think, Amita and Aisha?
I have a question. Is this qualify as sepsis or no? Or because if the temperature is low, we don't say that this is sepsis?
Okay, that question I'll answer later. Okay, can we answer it later?
Yes,
but just remind me if I forgot. Just remind me. We'll talk about a little bit about
Dr. Mesa, I'm taking notes, so don't worry. We will come back for that, inshallah. It's a very good question, by the way.
Okay.
So do you think he is sick? How much his sickness? Do you think there is any life-threatening issue with this patient? Okay.
His oxygen saturation is 88%.
He is significantly hypoxic, isn't it?
Yes.
Yeah.
Yes.
So if you measure your SpO2, how much should it be? In normal subject like me and yourself.
95 to 100%.
Oh my God, more than that. Is like, I would say 99 to 100%. So the 99 to 100. So rarely you will find a normal subject like myself or you with a saturation at the sea level less than 98%, unless you have a problem, unless we have a problem in our lung, like something chronic. But when somebody becomes sick and his saturation 88 is rarely sick patient. Okay. How about his breathing? He's breathing 32 per minute. What's the normal range for breathing? 10
12 to
18. 10 to 18 is our, like 12 to 18, our normal rate per minute, okay? So this is, you can see it at least double, okay? So this is double what? Double the normal rate of breathing, okay? So that means there is a significant process, very sick patient. Their significant process make somebody breathe double his normal rate, and you know why, to compensate for something else, isn't it?
Mm-hmm.
What else?
He's tachycardic.
True, he is tachycardic, so, though it's mild, but again, it's significant. If you come now and measure my heart rate, or I measure your heart rate, how much you think it will be? Young, let's consider you guys very young, but I am young also. So how much you think it would be? The resting
70 and 100.
probably
Between
60
70
to
and
70,
100.
60 to 70,
Yeah.
unless I just came from the gym or I ran, or you know, these things, or I got good news or bad news, you know. So it would be something 70 to, and maximum probably 90, and sometimes a little bit of that. But this is 110. That's, I mean, this is abnormal in somebody who is resting, sitting on a chair, not doing anything in the ED, just looking at people, and his heart or her heart rate is 110. So why I'm elaborating vital signs? Because the vital signs telling you first thing, this patient is alive or dead, okay? So this patient, we know he's alive, he has some vitals, okay? But again, the vitals tell you how much is this patient sick. Dr. Abdullah, why I'm elaborating on this? Because to be honest with you, this is the second important thing after history taking, because that what prioritized thing in terms of management of this patient. There is something called situational awareness. You should be aware that this patient is really sick. You should detect this early. You should tell everybody around you, help me, this patient is really sick. Don't leave him like this, not even for 1 minute. Message
Yes.
reached? Yes, okay, thank you.
Never. That's something you need to keep in mind. Never underestimate tachycardia. Okay, tachycardia is a really dangerous sign. Okay, always patients who are tachycardic, pay attention to them. Okay, so let's move on.
Yeah, Aisha and Maitha and Dr. Abdullah, this is very important note probably you can take. You don't need to fix this patient at your level. You don't need to get the accurate diagnosis, but you need to tell somebody else that I have a very sick patient, okay? So you should be able to recognize the sick patient, the moderately sick patient, and the very sick patient. And you should escalate it or involve somebody to help you, okay? So that's your part at least, okay?
Okay, so general examination. So what things you would look for in general examination? You took the vitals. What things you would look for in the general exam for this patient?
Is the patient alert? Is he a lot like awake, or is he loss of consciousness?
Yeah. So basically that translates to GCS.
Yes.
Why is that important in patients with respiratory problem? Why is that important? Because if the GCS is lower than 8, this patient is a candidate for intubation. Okay, so always when you assess any patient, you start with ABC. A is airways. So please look for things that would tell you that the airways are compromised. What things you would look for? First of all, alert GCS, let's say. So if the patient has a GCS less than 8, then this patient needs to be intubated. So you call the ICU. The second thing, you look for stridor. You look for airway foreign body, for example, in the airway, or choking, or airway compromise. You look for those things in general examination. If you don't have those things, then that clears your A. So this patient has an intact airways. He can protect his airways. Okay, but if you don't, if you have any doubt if that patient might have an airway compromise, then you need to take further action. You call the ICU. This patient might have might be a candidate for intubation. Okay, you got it?
Yes.
Okay, so general examination, let's quickly go over it. So this patient was in distress. He's not paler. He doesn't have any jaundice. He doesn't have any peripheral or central cyanosis. There was no clubbing. He's not diaphoretic. He's not using his accessory muscles, okay? So this is the physical examination. And the patient is lying at 30 degrees on the bed. Cardiovascular examination was unremarkable. There was no lower limb edema, no murmurs, heart sounds are present, no distant heart sounds. I'm asking about distant heart sounds because remember, pericardial effusion and tamponade can give you distant heart sounds. Okay.
What about
the other
a friction rub?
Yeah.
Since he said he had pleuritic chest pain, did we hear a friction rub? Does this count as
Okay.
CVS or respiratory?
Yeah. Okay. So there was no pericardial rub, but again, pericardial rub. It's an interesting sign where sometimes you can hear it, sometimes you don't. I mean that, if you hear that on the patient and you came after 5 minutes examining the same patient, you might not hear it. Okay. So there was no pericardial rub. What other things you would want to ask about the cardiovascular examination?
Pulse, is it regular?
Yeah, it's regular pulse, no radial delay, pulse is oral present. Okay, let's go to the RISP exam. I'm sorry, I'm going a little fast because I want to just, we have only 30 minutes left. So let's go to the respiratory examination. So what things you would do in the respiratory examination? This is the case, yani. This is the most important part of the exam. So what things you would start with in the respiratory examination? Go with what we were you taught in the medical school. So you start first with what? With the inspection. So tell me what things you would want to look for.
Nasal flaring, any asymmetry, any if they're tripod, if they assume different positions in order to help them breathe, pursed lips, if they have abdominal breathing.
Okay, so the type of breathing, first of all, they don't have any wheezing, they don't have any flares, they don't have any they're breathing fine from their mouth. This patient, what other things you would look in the inspection? Chest wall abnormalities. There were no chest wall abnormalities. Remember, chest wall. Sorry.
The use of accessory muscles.
Yeah, he doesn't use his accessory muscles. Okay. So that's inspection. Let's go to what comes next in the RISP exam.
Palpation.
Palpation. So what things you would do? Chest expansion.
Chest expansion.
Yeah. Okay. So chest expansion. The chest is asymmetric in examination. So the right side kind of does not expand compared to the left side. What other things you would do that? What other things you would look for?
Shift of the trachea from the midline.
Good. Yes, the trachea is in the midline. Why you look for tracheal deviation? What things that will give you tracheal deviation?
على حسب إذا it's shifted يعني toward the region ولا away from the region. It could be.
So if I tell you that your name is Aisha, صح? Yeah, if I told you, Aisha, I have a patient with tracheal deviation, what is the first thing you need to rule out? The first thing you need to make sure that this patient doesn't have, because this thing can kill them.
Tension pneumothorax.
Yes, exactly. Tension pneumothorax. Okay, tension pneumothorax gives you tracheal deviation away from the lesion side, or away from the side which has tension pneumothorax. Other things in palpation you want to look for, or you need to ask me about things you would do in the palpation part.
Tactile fremitus, does that count as palpation?
Yes, tactile fremitus is reduced on the right side. Then what comes next after palpation?
Percussion.
Percussion. So the chest is all most of the chest is tympanic, but on the right lower side there was dullness on percussion. Okay, then you go for auscultation. all breath sounds were there in both chests, but on the right lower zone of the chest, the breath there were reduced breath sounds. Okay, so please, when you see a patient, you all the first thing you need to do when you do the examination, if this patient is really tachypnic, if you listened and you saw there was an absent lung sounds or breathing sound on one side of the chest, and then you percuss and you saw that this is hypertympanic percussion, what do? You put a needle. You do needle decompression. A bad physician will diagnose tension pneumothorax with X-rays. Okay? Tension pneumothorax, you need to diagnose it with clinical examination. Hear the chest, no sounds, percuss. If there was hypertympanic lung or hypertympanic chest, then do needle decompression. Okay, you just insert a needle and then the air will come out and the patient, then you insert the chest tube, then that comes like a surgical intervention. That's not for you, but I mean, you need to recognize it as well at first. Okay, so that's what the respiratory examination showed in this patient. Other examination were fine. So GI examination, neurological examination, they were fine. So just to just say one thing about the GI and the neurological examination, you need to look for ascites in patients with shortness of breath, because ascites can give you effusion, and that effusion can cause shortness of breath. Okay, so look for signs of ascites, abdominal distension, fluid thrill, signs of ascites. Other things, neurological examination, weakness. Why I'm asking about weakness? Which disease can give you tachypnea and weakness? Think about what are the differentials of patient presenting with weakness and tachypnea?
Could be any disease that affects the nerve. For example, Guillain-Barré goes up. Maybe like a neuromuscular disease.
True.
Yeah,
some affects the respiratory wall.
Yeah, you're right. Myasthenia and Guillain-Barré syndrome. Those are typical in the exam. A patient had diarrhea, presented with weakness, ascending paralysis, and then he suddenly became short of breath. That's Guillain-Barré syndrome. And myasthenia patients as well, they get myasthenia crisis, where they have shortness of breath and increased respiratory demand in those set of patients. Okay, so now you have examined this patient. What
Dr. Abdullah, I guess Dr. Abdullah, for examination, I just want to re-emphasize what you started with. So the general exam, make sure that you look for the red flags in somebody with shortness of breath, because you don't want to miss it, as you said. So look for stridor, look for no air movement. So if somebody trying to breathe, but there is no air movement, or there is silent breath, okay? As one of the students mentioned also, the mental status, this is a red flag. Again, if it changed, look for arrhythmias if the patient in the ED and the monitor is there. That's another. So there are a set of red flags that you should be aware of. Your situational awareness is ready to pick up, because your action will be different. Okay.
Yeah. Okay. So what investigations you would do for this patient? Mesa or Asha, any one of you?
Start with the chest X-ray.
No, before that, just X-ray. You need to call the radiologist. You need the technician to come. Something you can do quicker than X-rays. Yeah, the X-ray is definitely part of investigation, but something you start with. Things that are quicker.
CBC.
What is that?
CBC.
Okay. So usually when you discuss any case with any examiner, you don't you start the investigations. Usually when you say the quicker things first, then you say things you would do in the blood, then you say radiological investigations. Okay, so the first things you need to do in any patient with dyspnea, two things: ECG and ABG. Okay, Know those. ECG, electrocardiogram, and ABG, arterial blood gas. Okay, you need to do those two things first.
So
Okay.
Abdullah,
Now,
actually, this is excellent message from you. I like that. So what Dr. Abdullah trying to say, you do the investigation that can come very fast and help you immediately. So when you are bedside with the patient, there are two types of investigation. There is a bedside investigation, and there are investigation or workup which take place in different places, like laboratory and so on. So what you have bedside, you have, for example, you already finished your set of vitals. You can do SpO2, you can do blood gas because the machine in the emergency department or near to you, and you can do an ECG, and actually even the X-ray. Now we have machine in the ED, so in
portable.
5 minutes, if you can get, in 5 minutes you can get. So this, there are two things important about this. The first thing, those are very easy, fast, and actually those are more important than other labs. So for example, when you do chest X-ray and you immediately pick a pneumothorax, you got the diagnosis. If you do blood gas and you get a picture of, like for example, DKA causing shortness of breath and dyspnea, you immediately diagnose the patient. The CBC and the biochemistry will take like 1 hour to 2 hours, and that will go to the lab. So by that time, your patient probably in very bad shape. So this is good message. I like it. Thank you.
Yeah. So ECG, you look for arrhythmias, you look for electrical alternance, which can cause MI. You need to make sure that the patient is not having an MI. So those are the things that you need to really look for ECGs. Always look for things that can kill, okay? Tamponade, MI, those things can kill the patient.
Excellent.
ABG.
So this is another very good point, Dr. Abdullah, thank you. So when you exposed to a patient who is sick and his vitals abnormal, like this, in this case, shortness of breath and chest pain, you need to have a set of differential diagnosis for red flags or for killers or for emergencies. There is different from somebody who is sick because of emergency disease or not. So that differential diagnosis should be in your mind as a reflex, you should not think about it. So when you get somebody with chest pain and shortness of breath, so the emergencies are an MI, pulmonary embolism, you get a pneumothorax, you get somebody with esophageal rupture, and flash pulmonary edema. So this should be a set of differential diagnosis, which you should have it in 1 second. Okay.
Okay. So the other things, now you would do the ECG, we said the ABG. So what things you would look at in the ABG? So ABG, how do you approach ABG?
We check our shared pH.
Okay, so هذا for acid-base balance, but you're right. Now the first thing you need to look at is the PO2 and the PCO2. Okay, in patients with respiratory distress. Okay, you're right. I mean, in acid-base balance, you look at the pH and then you look on the bicarbonate and the CO2. But I'm talking about patients with respiratory distress. You need to look at the PO2 and PCO2. The PO2 tells you about the oxygenation level in the patient, and the PCO2 tells you about the CO2 level. So usually in patients with reduced PO2 and normal to reduced PCO2, this is called type 1 respiratory failure. Okay, so hypoxic respiratory failure. The patient is hypoxic, reduced PO2. Now, the other type of respiratory failure, which is type 2, hypercapnic respiratory failure, which the patient has CO2, increased CO2 or CO2 retention. So ABG can tell you that this patient has either type 1 or either type 2. Now, why is that important? Because you can classify the severity of this patient according to the ABG. For example, let's say a patient presented with asthma exacerbation. Okay, asthma exacerbation, and you noticed that the PCO2 of this patient is going up. So if your PCO2 is going up in a patient who is asthma exacerbation, you know that this patient is really sick, because the muscles are tiring, and the patient is retaining CO2 in a disease which usually cause hypoxic respiratory failure. فهمتوا علي ولا I think I'm confusing you?
I can make it a little bit simpler, Dr. Abdullah. So what Dr. Abdullah trying to say, the ABGs will help you, give you a picture about oxygenation. So you look at the BO2, and then it will help you with ventilation, tell you how good is the ventilation, which is BCO2. So BCO2 reflect what? Reflect the ventilation. And then, as you suggested, it will tell you actually about the acid-base status, which is again related to the process of oxygenation, ventilation, and overall ongoing process. What Dr. Abdullah telling you, that the level of oxygenation and ventilation is very important to predict what is the cause of this disease, but also how sick is the patient. So what Dr. Abdullah example, for example, said, if somebody with acute asthma or COPD exacerbation, and you see on their blood gas that CO2 is going up and up and up, that means they cannot ventilate anymore and they will stop at some time. So again, ABG is oxygenation, ventilation, acid base. You look to the three components, and then you should decide how sick is the patient and what sort of intervention you need to do.
Yes. So and also the ABG can help you in deciding how to manage this patient. We will go into that
Dr.
point.
Abdullah, by the way, now for our ABGs these days, you can get lots of information. So you can get the oxygenation, ventilation, and then you can get the acid base. And then also there are other components that like the hemoglobin level, electrolytes, and even lactate level. So alhamdulillah, these days, the blood gas machine can be a sort of replacement for the laboratory hematology and biochemistry. So it can give you fast information. In 2 minutes, you can get lots of information. So my advice for you, when on Sunday, inshallah, you go to the hospital or to the ED, try to look to these ABGs and try to get the maximum benefit from it. You will find lots of information on the ABG sheet.
Yeah, so let's go. We have only 10 minutes. So let's go to the laboratory investigations you would ask in this patient. What things you would order? Mesa, Asha?
Troponin.
Excellent, good.
Okay, cardiac enzymes, troponin, and what? And BMP, if you think if this patient might have a cardiac cause. What other things you would ask?
Markers.
Inflammatory markers, which are? Be specific.
CRP.
CRP.
SR.
Procalcitonin. You would ask, of course, of CBC, UNE, which are the electrolytes. Those are usually the basic investigations you would do in any patient who is dyspneic. Then you would do also D-dimers if you think that this patient might have a PE. Okay, so you can add a D-dimer. Okay, so those are the investigations you would order, and then you do X-ray. Okay, just X-ray. So let me tell you what this patient had. So first of all, the sodium was 136. Or let me go back. Talk to tell you about the ECG and the ABG first. So the ABG, the PO2 is 80, the CO2 is 31.1, the bicarb is 22, the pH is 7.45. The ECG for this patient showed only sinus tachycardia, no other abnormality in the ECG. Labs, sodium, I'll just say normal or abnormal because numbers, the important things I would say. sodium, potassium, creatinine, urea, they were all normal. Glucose was 19.7. BNP was 200. BNP is normal. Troponin were normal. WB count was 11.3. Hemoglobin was 13.3. CRP was 300. Procalcitonin was 1.8, which is high. LDH was 453, which is high. And there was no more of neutrophilic predominance in the differentials of the WB count. Okay, so that was those were the labs. Now the X-ray showed. I don't know if you can show the X-ray for this patient.
Yes, there we can see it.
Yeah. So this is the X-ray. Tell me, what do you see in this X-ray? Metha, Asha, any one of you?
I see. Okay, so should I do the ABCD or should I just say what I think what I see?
Only the positive findings for now, because
that's
So
fine.
It looks like it's a pleural effusion. There's the costophrenic angles are completely gone, and it's not the entire. You can't even see the cardiac borders anymore. For me, it looks like a pleural effusion.
Yeah. So there is a blunting of the right costophrenic angle, and obliterating of the right of the cardiac borders. So this probably goes with pleural effusion. Okay. You always, in describing clinical findings, you always say probably, most likely. You don't say 100%, okay? Always, to be safe in the exams. Okay, so this patient was admitted as a case of pleural effusion. Now, when you see this patient, what things you would also do? Now, when this patient is admitted, he's in the ward, you are the physician taking care of this patient, what other investigations you would do?
Sputum culture.
Before, okay, sputum culture, I agree 100%. But other things you would do for the fusion. Let's talk about the fusion.
I would want to get a
Sorry?
Thoracocentesis.
Okay, before doing thoracocentesis, you need to do what? You need to see how much is the fusion. So you would do ultrasound chest. Yes. You can go either with ultrasound chest, or you can do a CT. Okay? CT chest, which can give you more. How what? Sorry?
How would CT help us?
Yeah, I'll tell you how. So CT will quantify the fluids, okay? Will tell you how much fluid is it. And also the ultrasound will quantify the amount of fluid. The other thing that can help you with the CT, not the ultrasound, say for example, this patient might have a malignant pleural effusion. So pleural effusion related to malignancy. So in CT, you would see that the tumor. In CT, you would see if there are any pneumonia changes or infective changes in the lung. So CT will give you more visualization of the lung and the underlying processes in the lung themselves. But
so Dr. so just to make it fast and brief, actually the X-ray, the ultrasound, and the CT, all of them, they can help you, okay? But the sensitivity and the specificity for what you are looking for is the different one. So as Dr. Abdullah said, if you wanted to drain this fluid, you may put the ultrasound probe and see how much is that fluid. If it is a significant volume where you can put a needle and take a sample and do something with it, that's good. But if you want more information, the gold standard is a CAT scan chest, because that will be of more details. So just depend what you want to do. If you wanted to do simple thoracocentesis, as you said, in the old time, we do it blindly. We just do some percussion on the chest, determine the level of fluid, we go with the needle. That's what I did when I was a resident initially. Those days we got the ultrasound. It is even in the floor, not even in the X-ray department. So you can see the fluid live, and you go with the needle using the ultrasound. But if you want more information, yes, you can go for CAT scan. So it depends what you want. So if you only want sample of that pleural effusion, it's very reasonable to go with ultrasound now.
Yeah. So you do thoracocentesis, which means you take a sample of the pleural effusion. Okay. Now you have the fluid sample. So what things you would order? What things you would look for in the fluid sample? So what things that will help you to manage this patient in the pleural effusion sample itself?
I would look for protein levels.
Yeah,
Protein level and
LDH levels, any sort of
LDH.
Yes.
So there is a criteria, famous criteria that
Right.
tells you if this patient has an exudate or transudate.
light criteria.
Yes.
Exactly, right criteria. So what is the light criteria? Give me the three things, the three rules out, the three criteria.
The LDH should be above I think plasma levels or normal levels. I can't remember the exact values.
Okay, so I'll tell you the light criteria. Sorry, عشان time. So pleural protein over serum protein more than 0.5, pleural LDH over serum LDH more than 0.6, pleural LDH more than the 2/3 of the upper level of normal LDH. Okay, so those are the light criteria. Any one positive of them indicates that this is an effusion. This is I mean an exudative effusion. So the first thing, okay, so let's organize our thoughts. The first thing in managing pleural effusion is identifying the cause. Okay, so what's the cause? Is it transitive or exudative effusion? Is it because of increased hydrostatic pressure of this patient or reduced oncotic pressure, which give you a transitive picture, or it's because of the local inflammatory cause that can give you exudative picture? So the transudate pleural effusion, usually three things. Okay, memorize three things for the exam: heart failure, nephrotic syndrome, and cirrhosis. Know those three. Usually transudate effusion, usually they are bilateral, but sometimes they can be unilateral. Okay, so those three things, memorize them. Now the exudate effusion, there are many things. So it could be malignancy. This is the first thing. The second thing could be infection, parapneumonic infection. That's the second thing. The third thing could be inflammatory, like rheumatoid arthritis, SLE, other things.
Abdullah, are we going to stop sharp at 1 or we can take more time?
I think we can take like a 10 to 20 minutes more. Okay. Yeah. So I'll just go briefly to over the case. So that's what you do for those patients in pleural effusion.
You probably you can look for cell count, gram stain. You send some microbiology culture, and in case you think of malignancy, probably cytology study.
Yeah.
Also. Okay.
Yes. So you look for those things, and this patient had a high white cell count in the effusion, and he was treated with antibiotics. Chest tube was inserted because the fluid was purulent in shape. Chest tube was inserted, and the fluid was drained, treated with antibiotics, and the patient improved. And
so what do you call that, Dr. Abdullah? What's
we call that empyema. So that was the diagnosis. So just I'll go just very quickly through the pleural effusion workup, and then we go to overview on dyspnea. So pleural effusion, either transudate or exudate. Transudate, no 3, heart failure, nephrotic syndrome, cirrhosis. Exudate, it either be infectious or non-infectious. Infectious, think of three things: bacterial infection or parapneumonic infection, TB, and fungal infections. Okay, those are rare. So for TB, you would send for the culture fast acid stain, and you would look for something called adenosine deaminase. They come in the exams a lot, so know that. Adenosine deaminase. levels. If it's high, then most probably it's the TB. The non-infectious look for rheumatoid arthritis or autoimmune malignancies. Those are usually the most common things. So malignancies, please do cytology level. Why you do cytology? Because if you did cytology and you saw cells in the lung, in the pleural effusion, cytology was positive, then that gives you the staging as well. So this is stage 4. Okay, let's help you يعني تضرب عصفورين بحجر واحد. Okay. So let's go back to dyspnea. Let's talk about the differential diagnosis of dyspnea. How do you approach dyspnea as a overview? So dyspnea, we can define it to classify it into 3 categories. First of things, cardiac. The second thing is pulmonary. The other things, others. Okay. So cardiac, look for arrhythmias, MI, pericarditis, myocarditis, valvular disease. Okay, so pretty much most of the cardiac diseases give you shortness of breath. The second thing is pulmonary. Now, pulmonary, we can differentiate it into many types. So there is airway disease, there is parenchymal disease, vascular disease, and pleural diseases. So airway diseases, look for airway obstruction, asthma, COPD, for example, anaphylaxis or foreign body. Those are airway disease. Mucus plug, if you have a mucus, very thick mucus plugging the airways, those are airway diseases. Now, parenchymal diseases, usually pneumonia, cancer, interstitial lung disease. Then you go for vascular, which is most probably PE, okay? And then you go for pleural effusion, pleural diseases, which is pneumothorax and pleural effusion. Now, I just want to touch upon one more thing, which is آخر شيء. When you start seeing any patient who is hypoxic, you start giving them oxygen, okay? So usually they ask you this in the exams. That's why I want to cover this. So oxygen levels, you have 4 types, let's say 5 types of oxygenation. So you have a nasal cannula, you have a face mask, then you have non-rebreather mask, then you have non-invasive ventilation, then the last thing is mechanical ventilation or intubation. Okay, so that's when you intubate the patient, you put them on a machine that do the respiration for them. So the first thing, face nasal cannula, goes up to 5 liters of oxygen. Face mask goes up to 10 liters of oxygen. Non-rebreather goes to 15. Then you have the non-invasive ventilation, which is CPAP and BiPAP. And the last thing is intubation. You always escalate. So this patient, you put them in the nasal cannula first. Then if it doesn't work, you go to the face mask. Then you go to the non-rebreather. Then you go to other things. Usually, we want patients to have an oxygen saturation above 94, except in patients who are COPD patients. You keep the saturation between 88 to 92. And usually nurses will not understand this. In patients with COPD, they like to have the CO2 level, the oxygen saturation above 100 or 100. That's wrong. You need to keep the saturation between 88 to 92 in COPD patients. So I think, I'm sorry, I went fast covering dyspnea and oxygen therapy. Do you have any questions for us? Me, Dr. Ali, if you want to add anything, then we can.
Excellent, Abdullah. Because the time, we run out of time, just I would like to say this is a very good introduction to dyspnea. And as you can see, this is not enough. Don't feel that you are lost. No. So you will need long time till you get everything and know everything about dyspnea or shortness of breath. And I think probably for the upcoming interactive sessions, probably we should concentrate on each part. Like, for example, the examination of dyspneic patient, the investigation, and the management part. So we cannot do it on one part, but this is a very good introduction. as I said before, just keep in mind that you are not responsible to fix those patients. Do everything yourself. The good thing, just come with a broad differential diagnosis history-wise, come with a broad differential diagnosis examination-wise, and then keep your management plan open and include everything at this level. And keep this every day you go and see patient with dyspnea. So every day you go see patient with dyspnea, as you did today, you will include everything. Not only you don't fixate or be tunneled on one thing, no, you look at broad spectrum of differential diagnosis, but otherwise, excellent. Should we elaborate on a little bit, only half a minute, on the question of sepsis?
Yes.
So that's good point. So I congratulate you first for asking that question, because sepsis is the biggest killer in our hospitals. And we will not discuss what is sepsis here, but you are right. Anybody comes with shortness of breath, cough, or fever, if you put it in your mind, does this patient has sepsis, then you will pick it up. If you don't, you may not. Okay, but simply sepsis is organ dysfunction, and this patient does have organ dysfunction. Actually, this patient is very tachypneic and he has desaturation, so this is organ failure plus a source of infection, which is the pleural effusion or the pneumonia. This is sepsis. I agree with you. So it's true, this patient does have sepsis. So again, sepsis, organ dysfunction due to dysregulated host response to infection, simply. So you need to have infection plus organ dysfunction. Then this patient simply have sepsis, and you should manage him the way you manage a bad medical process, which is sepsis. So I think that's the question I remember that you guys were looking for an answer for.
Can I add one point, Victor?
Yeah, sure.
For sepsis, please, I beg you, pay this in attention, okay? Do not diagnose sepsis with absence or presence of fever. Fever has nothing to do with sepsis. Okay, so please, not any patient who is afebrile means that he doesn't have sepsis. Okay, sepsis, as the doctor said, organ dysfunction. Fever can point towards sepsis, but the absence of fever does not mean that this patient is not septic.
Yeah, good. Okay.
So we can take questions from the floor.
Yes, we can. Dr. Abdullah, Dr. Ali, honestly, I'm out of words. Thank you so much for this. I think it's one of the best cases that we've presented so far, and it's an interesting case, and the discussion was honestly amazing from my point of view. So I just wanted to thank you personally. If anyone from the floor has any questions to add, anything that you think is important in regards to this presentation?
I have a question.
Yes, go ahead, Maithaz.
Yes, from the labs, like how do we determine if it's viral versus bacterial? Yani, how do we know when to give antibiotics? Is it based on the labs, the neutrophils and whatnot?
Yeah.
Or?
So in this patient, the patient presented. So usually in pleural effusion, the most common cause is bacterial infection. Okay, so that's the most common cause. So in those patients, you give antibiotics. If it's viral, then the antibiotic will not help the patient, but it will not harm them. But if it's bacterial and you treated it as viral, the patient will deteriorate. So always give antibiotics, and usually patients with viral pleural effusion, they will spontaneously resolve. And one more thing, this patient, I didn't go through that, but in pleural fluid analysis, the color of the pleura or the appearance of the pleural fluid was purulent. So that goes more of empyema and bacterial infection. So the answer, short answer, give every patient with pleural effusion with suspected infection antibiotics. Okay, unless you prove that they have viral infection later on, you can stop the antibiotic if you want.
So Maitha, they are, when you use antimicrobials, there are two ways we use them. And answering your question, is it virus or bacterial? Unfortunately, the answer, we don't know when the patient came. So we have two type of treatment or using antimicrobials. One is empirical, as you know. The other one is definitive, means The empirical is blind. You don't know what's going on. You don't know what is the bug, but you know there is a bad infection rendering this patient very sick. So unfortunately, we cannot wait till we know what is causing this infection. So as Dr. Abdullah said, go ahead and give antibiotic very fast, okay? From the first minute you encounter this patient, he has fever, cough, chest pain, and after the x-ray, you see there is a big patch or opacification. Definitely immediately give a good option of antibiotic, okay? Now, the definitive, what Dr. Abdullah spoke about, when you drain that fluid and it's embyema, it's a pus, and probably you get a bug. So according to that bug, you will give the definitive antibiotic. If it turn out to be a virus, like depend what virus, for example, COVID-19 virus, you tested the patient and now you find this patient has COVID-19. You will give the treatment for COVID-19, for example, but unfortunately, again, it doesn't mean this patient does not have superimposed bacterial infection. So this is sort of a very good question, but also detailed question. So depend on the scenario, depend on the case by case. But it's very good question. So, but the message for us that don't delay the antibiotic, as Dr. Abdullah said, go ahead and give antibiotic in such a presentation.
We have one question from the floor from Nathan Yadi. What about the Q SOFA scoring system? Is it sensitive enough to detect sepsis?
Yes.
And when to use it?
Yeah, actually, you know what SOFA or quick SOFA is a score which is well validated in detecting sepsis. So as you understand from it, it's not for diagnosis of sepsis, it's for early recognition of sepsis. What does that mean? So for this patient, for example, that we discussed, you don't need to score the patient, quick SOFA or SOFA for the purpose of diagnosis. You need the quick SOFA or SOFA for the purpose of prognostication. Why? Because this patient does have cough, fever, hypotensive, hypoxemic. There is a patch on his X-ray, and he has respiratory failure. So the diagnosis of sepsis, a clinical syndrome, is already there. So in which patient it would be helpful? It will be helpful for any other patient in the hospital where you have uncertainty. Could this patient have sepsis or not? Should I start the line of management of sepsis or not? So for example, somebody who has fever, cough, but he's not that sick. So what you say, I would score him. He probably in sepsis or going to sepsis. So I'll do quick SOFA. So his Glasgow scale is 15 out of 15. His blood pressure is 130, but he is tachypneic, his respiratory 25. So he does have infection in his lung, making him tachypneic. But his score only 1 out of 3. It's not 2 out of 3, which is the positive one. So he is probably not in sepsis as of now. I will not activate the sepsis code or the sepsis line of treatment. However, if his mental status change and his Glasgow scale now 13 out of 15 plus the tachypnea, even if his blood pressure is normal, I would activate the sepsis bundle. So I will send for all the lab related to sepsis, and I will start antibiotic, I will start fluid, and so on. So the baseline or the end of the road answer is that this patient, the scoring is good for detection of sepsis, early determination and recognition of sepsis. Does that answer the question for quick SOFA, or you need to elaborate more? Was that answer
I think
enough?
I think it does answer.
Yes,
Okay.
yes, it does answer the question.
Okay,
We do
but
have
it's
another
good.
question.
So please, the quick SOFA, do it all the time. So if I guess elaborate on it a little bit, there are, if you Google quick SOFA, you'll find people in the United States, they made it as scoring system every shift in the hospital. So every shift in the hospital, like when the nurses comes every 8 hours, you know, they do a quick SOFA for all the patient. Why? To pick up possible sepsis that's not very clear for others, okay?
We do have another question from the floor from Mohammed Labedli. So what is the next step after 2 attempts of therapeutic thoracentesis that still did not resolve the effusion? So when should we go for decortication?
Okay, that's Yeah.
Can I answer?
Yeah, go ahead. Go ahead.
So decortication, and there are other measures, which is decortication, and then injecting the patient with the TPAs, اللي هو streptokinase, and other things. So you do that if you have an empyema, or if you have a loculated pleural effusion or multi-lobulated pleural effusion. In those patients, you start doing that, okay? But other patients with simple pleural effusion, you don't go to those measures, okay? So, Dr. Ali, if you want to add anything.
Yeah. Sorry, this depends on the case by case. It sounds like the question is the source control is not successful with drain, isn't it? So when we talk about empyema, for example, which is infection of the pleural cavity, and you put a small hose or a small pipe or drain, it may not clear because, as you said, there is septation because of the materials that leaked from the cells and the vessels to the pleural cavity, and there is fibrin component. So when you put the drain, it will not drain everything. Then you need to do further like source control by removing probably part of the pleura itself, or removing these fibrins. So these days, we are good in terms of you will use the CAT scan and get more detail about this pleural effusion. And then there is video assisted like intervention where they go inside and try to control the source more. If these two fails, then you can go for like a more aggressive way of decortication and surgical intervention. So the bottom line, that will be decided case by case. Does the antibiotic help? Does the chest tube help? If not, yes, you need to go and do more surgical source control.
Yeah, we have video assisted thoracoscopy. I'm sorry. And we have also something called pleurodesis, and that's, we do it in patients with the recurrent pleural effusion. For example, heart failure patients with recurrent effusions, you do pleurodesis as well.
So just to make it simple, it's like any other infectious collection in the body. You try with antibiotic. If it is sizable where you can remove it, you go with a drain, a non-invasive one, like through the interventional radiology. If that's not enough, unfortunately, you need to open and remove that source surgically. Okay.
Any questions?
So any more questions? I think if there aren't any more questions, we can end today's session.
Yeah, you can always ask me if you have my contacts. You can always ask me anything about dyspnea or any other medical questions. I'm open to all questions anytime. Okay, and thank you all for attending this session. Thank you for the discussants. Thank you for Dr. Ali Shidi for being here, and thank you for the organizers.
Thank you, everyone. Thank you, Dr. Ali. Thank you, Dr. Abdullah, and our discussants. Thank you so much for this amazing discussion.
It's my pleasure. Thank you for involving me, and I hope you all the best. I hope you get some benefit from this presentation.
Inshallah. Thank you, everyone.
Thank you.
Bye-bye. Enjoy the weekend.